Yellow fever is an acute viral disease. In most cases, symptoms include fever, chills, loss of appetite, nausea, muscle pains particularly in the back, and headaches. Symptoms typically improve within 5 days. In some people, within a day of improving, the fever comes back, abdominal pain occurs, and liver damage begins causing yellow skin. If this occurs, the risk of bleeding and kidney problems is also increased. The disease is caused by the yellow fever virus and is spread by the bite of an infected female mosquito. It infects only humans, other primates, and several species of mosquitoes. In cities, it is spread primarily by mosquitoes of the Aedes aegypti type. The virus is an RNA virus of the genus flavivirus. The disease may be difficult to tell apart from other illnesses, especially in the early stages. To confirm a suspected case, blood sample testing with polymerase chain reaction is required. A safe and effective vaccine against yellow fever exists, and some countries require vaccinations for travelers. Other efforts to prevent infection include reducing the population of the transmitting mosquito. In areas where yellow fever is common and vaccination is uncommon, early diagnosis of cases and immunization of large parts of the population is important to prevent outbreaks. Once infected, management is symptomatic with no specific measures effective against the virus. The second and more severe phase results in death in up to half of people without treatment. Yellow fever causes 200,000 infections and 30,000 deaths every year, with nearly 90% of these occurring in Africa. Nearly 1 billion people live in an area of the world where the disease is common. It is common in tropical areas of South America and Africa, but not in Asia. Since the 1980s, the number of cases of yellow fever has been increasing. This is believed to be due to fewer people being immune, more people living in cities, people moving frequently, and changing climate. The disease originated in Africa, from where it spread to South America through the slave trade in the 17th century. Since the 17th century, several major outbreaks of the disease have occurred in the Americas, Africa, and Europe. In the 18th and 19th centuries, yellow fever was seen as one of the most dangerous infectious diseases. In 1927, yellow fever virus became the first human virus to be isolated. Signs and symptoms. Yellow fever begins after an incubation period of 3 to 6 days. Most cases only cause a mild infection with fever, headache, chills, back pain, fatigue, loss of appetite, muscle pain, nausea, and vomiting. In these cases, the infection lasts only 3 to 4 days. In 15% of cases, however, people enter a second toxic phase of the disease with recurring fever, this time accompanied by jaundice due to liver damage, as well as abdominal pain. Bleeding in the mouth, the eyes, and the gastrointestinal tract will cause vomit containing blood, hence the Spanish name for yellow fever, vomito negro. There may also be kidney failure, hiccups, and delirium. The toxic phase is fatal in about 20 to 50% of cases, making the overall fatality rate for the disease about 3.0 to 7.5%. However, the fatality rate of those with the toxic phase of the disease may exceed 50%. Surviving the infection provides lifelong immunity, and normally there is no permanent organ damage. Cause. Yellow fever is caused by the yellow fever virus, a 40 to 50 nanometer wide enveloped RNA virus, the type, species, and namesake of the family Flaviviridae. It was the first illness shown to be transmissible by filtered human serum and transmitted by mosquitoes, by Walter Reed around 1900. The positive sense, single-stranded RNA is around 11,000 nucleotides long and has a single opened reading frame encoding a polyprotein. Host proteases cut this polyprotein into 3 structural and 7 non-structural proteins. The enumeration corresponds to the arrangement of the protein-coding genes in the genome. Minimal yellow fever virus 3 (UTR) region is required for stalling of the host 5-3 exonuclease XRN1. The UTR contains PKS3 pseudoknot structure, which serves as a molecular signal to stall the exonuclease and is the only viral requirement for subgenomic flavivirus RNA production. The SFRNAs are a result of incomplete degradation of the viral genome by the exonuclease and are important for viral pathogenicity. Yellow fever belongs to the group of hemorrhagic fevers. The viruses infect, amongst others, monocytes, macrophages, and dendritic cells. They attach to the cell surface via specific receptors and are taken up by an endosomal vesicle. Inside the endosome, the decreased pH induces the fusion of the endosomal membrane with the virus envelope. The capsid enters the cytosol, decays, and releases the genome. Receptor binding, as well as membrane fusion, are catalyzed by the protein E, which changes its conformation at low pH, causing a rearrangement of the 90 homodimers to 60 homotrimers. After entering the host cell, the viral genome is replicated in the rough endoplasmic reticulum and in the so-called vesicle packets. At first, an immature form of the virus particle is produced inside the whose M protein is not yet cleaved to its mature form and is therefore denoted as PRM and forms a complex with protein E. The immature particles are processed in the Golgi apparatus by the host protein furin, which cleaves PRM to M. This releases E from the complex, which can now take its place in the mature infectious virion. Transmission: yellow fever virus is mainly transmitted through the bite of the yellow fever mosquito Aedes aegypti, but other mostly Aedes mosquitoes such as the tiger mosquito can also serve as a vector for this virus. Like other arboviruses which are transmitted by mosquitoes, the yellow fever virus is taken up by a female mosquito when it ingests the blood of an infected human or other primate. Viruses reach the stomach of the mosquito, and if the virus concentration is high enough, the virions can infect epithelial cells and replicate there. For that, they reach the hemocoel and from the salivary glands. When the mosquito next sucks blood, it injects its saliva into the wound, and the virus reaches the bloodstream of the bitten person. Transovarial and transstadial transmission of the yellow fever virus within Aedes aegypti, that is, the transmission from a female mosquito to her eggs and then larvae, are indicated. This infection of vectors without a previous blood meal seems to play a role in single, sudden breakouts of the disease. 3 epidemiologically different infectious cycles occur, in which the virus is transmitted from mosquitoes to humans or other primates. In the urban cycle, only the yellow fever mosquito aegypti is involved. It is well adapted to urban areas and can also transmit other diseases, including Zika fever, dengue fever and chikungunya. The urban cycle is responsible for the major outbreaks of yellow fever that occur in Africa. Except in an outbreak in 1999 in Bolivia, this urban cycle no longer exists in South America. Besides the urban cycle, both in Africa and South America, a silvertich cycle is present, where Aedes africanus are mosquitoes of the genus Haemogogus and Sabethes serve as vectors. In the jungle, the mosquitoes infect mainly non-human primates. The disease is mostly asymptomatic in African primates. In South America, the silvertich cycle is currently the only way humans can become infected. which explains the low incidence of yellow fever cases on the continent. People who become infected in the jungle can carry the virus to urban areas, where aegypti acts as a vector. Because of this silvertich cycle, the yellow fever cannot be eradicated. In Africa, a third infectious cycle known as savanna cycle or intermediate cycle occurs between the jungle and urban cycles. Different mosquitoes of the genus Aedes are involved. In recent years, this has been the most common form of transmission of yellow fever in Africa. There is concern about yellow fever spreading to Southeast Asia, where its vector Aedes aegypti already occurs. Pathogenesis. After transmission from a mosquito, the viruses replicate in the lymph nodes and infect dendritic cells in particular. For that, they reach the liver and infect hepatocytes, which leads to eosinophilic degradation of these cells and to the release of cytokines. Apoptotic masses known as Councilman bodies appear in the cytoplasm of hepatocytes. Fatality may occur when cytokine storm, shock, and multiple organ failure follow. Diagnosis. Yellow fever is most frequently a clinical diagnosis made on the basis of symptoms and the diseased person's whereabouts prior to becoming ill. Mild courses of the disease can only be confirmed virologically, since mild courses of yellow fever can also contribute significantly to regional outbreaks. Every suspected case of yellow fever is treated seriously. If yellow fever is suspected, the virus cannot be confirmed until 6 to 10 days after the illness. A direct confirmation can be obtained by reverse transcription polymerase chain reaction, where the genome of the virus is amplified. Another direct approach is the isolation of the virus and its growth in cell culture using blood plasma. This can take 1 to 4 weeks. Serologically, an enzyme-linked immunosorbent assay during the acute phase of the disease using specific IgM against yellow fever or an increase in specific egg titer can confirm yellow fever. Together with clinical symptoms, the detection of IgM or a fourfold increase in egg titer is considered sufficient indication for yellow fever, since these tests can cross-react with other flaviviruses like dengue virus. These indirect methods cannot conclusively prove yellow fever infection. Liver biopsy can verify inflammation and necrosis of hepatocytes and detect viral antigens. Because of the bleeding tendency of yellow fever patients, a biopsy is only advisable post-mortem to confirm the cause of death. In a differential diagnosis, infections with yellow fever must be distinguished from other feverish illnesses like malaria. Other viral, hemorrhagic fevers, such as Ebola virus, Lassa virus, Marburg virus, and Janine virus, must be excluded as cause. Prevention. Personal prevention of yellow fever includes vaccination, as well as avoidance of mosquito bites in areas where yellow fever is endemic. Institutional measures for prevention of yellow fever include vaccination programs and measures of controlling mosquitoes. Programs for distribution of mosquito nets for use in homes are providing reductions in cases of both malaria and yellow fever. Vaccination is recommended for those traveling to affected areas, because non-native people tend to suffer more severe illness when infected. Protection begins by the 10th day after vaccine administration in 95% of people and lasts for at least 10 years. About 81% of people are still immune after 30 years. The attenuated live vaccine STEM-17D was developed in 1937 by Max Eiler. The World Health Organization recommends routine vaccinations for people living in affected areas between the 9th and 12th month after birth. Up to 1 in 4 people experience fever, aches, and local soreness and redness at the site of injection. In rare cases, the vaccination can cause yellow fever vaccine-associated viscerotropic disease, which is fatal in 60% of cases. It is probably due to the genetic morphology of the immune system. Another possible side effect is an infection of the nervous system, which occurs in 1 in 200,000 to 300,000 cases, causing yellow fever vaccine-associated neurotropic disease, which can lead to meningoencephalitis and is fatal in less than 5% of cases. In 2009, the largest mass vaccination against yellow fever began in West Africa, specifically Benin, Liberia, and Sierra Leone. When it is completed in 2015, more than 12 million people will have been vaccinated against the disease. According to the WHO, the mass vaccination cannot eliminate yellow fever because of the vast number of infected mosquitoes in urban areas of the target countries, but it will significantly reduce the number of people infected. The WHO plans to continue the vaccination campaign in another 5 African countries: the Central African Republic, Ghana, Guinea, Ivory Coast, and Nigeria, and stated that about 160 million people in the continent could be at risk unless the organization acquires additional funding to support widespread vaccinations. In 2013, the WHO stated, "A single dose of vaccination is sufficient to confer lifelong immunity against yellow fever disease." Compulsory vaccination. Some countries in Asia are theoretically in danger of yellow fever epidemics, although the disease does not yet occur there. To prevent introduction of the virus, some countries demand previous vaccination of foreign visitors if they have passed through yellow fever areas. Vaccination has to be proven in a vaccination certificate which is valid 10 days after the vaccination and lasts for 10 years. Although the WHO on the 17th of May 2013 advised that subsequent booster vaccinations are unnecessary, an older certificate may not be acceptable at all border posts in all affected countries. A list of the countries that require yellow fever vaccination is published by the WHO. If the vaccination cannot be conducted for some reasons, dispensation may be possible. In this case, an exemption certificate issued by a WHO-approved vaccination center is required. Although 32 of 44 countries where yellow fever occurs endemically do have vaccination programs, in many of these countries, less than 50% of the population is vaccinated. Vector control of the yellow fever mosquito aegypti is of major importance, especially because the same mosquito can also transmit dengue fever and chikungunya disease. Aegypti breeds preferentially in water, for example in installations by inhabitants of areas with precarious drinking water supply, or in domestic waste, especially tires, cans, and plastic bottles. These conditions are common in urban areas in developing countries. Two main strategies are employed to reduce mosquito populations. One approach is to kill the developing larvae. Measures are taken to reduce the water accumulations in which the larva develops. Larvicides are used, as well as larvae-eating fish and copepods, which reduce the number of larvae. For many years, copepods of the genus Mesocyclops have been used in Vietnam for preventing dengue fever. It eradicated the mosquito vector in several areas. Similar efforts may be effective against yellow fever. Pyriproxyfen is recommended as a chemical larvicide, mainly because it is safe for humans and effective even in small doses. The second strategy is to reduce populations of the adult yellow fever mosquito. Lethal ovitraps can reduce Aedes populations, but with a decreased amount of pesticide because it targets the mosquitoes directly. Curtains cans and lids of water tanks can be sprayed with insecticides, but application inside houses is not recommended by the WHO. Insecticide-treated mosquito nets are effective just as they are against the Anopheles mosquito that carries malaria. Treatment. As for other flavivirus infections, no cure is known for yellow fever. Hospitalization is advisable and intensive care may be necessary because of rapid deterioration in some cases. Different methods for acute treatment of the disease have been shown to not be very successful. Passive immunization after emergence of symptoms is probably without effect. Ribavirin and other antiviral drugs, as well as treatment with interferons, do not have a positive effect in patients. Asymptomatic treatment includes rehydration and pain relief with drugs such as paracetamol. Acetyl-salicylic acid should not be given because of its anticoagulant effect, which can be devastating in the case of internal bleeding that can occur with yellow fever. Epidemiology. Yellow fever is common in tropical and subtropical areas of South America and Africa. Worldwide, about 600 million people live in endemic areas. The WHO estimates 200,000 cases of disease and 30,000 deaths a year occur. The number of officially reported cases is far lower. Africa, an estimated 90% of the infections occur on the African continent. In 2008, the largest number of recorded cases were in Togo. In March 2016, the Chinese government confirmed the first imported case in a 32-year-old man who had been in Angola, the site of an ongoing outbreak of yellow fever. On the 28th of March 2016, ProMed Mail issued a warning that the yellow fever outbreak in Angola might spread further and that countries where dengue and the mosquito vector of dengue and yellow fever are present are at risk of a potentially outbreak of yellow fever. Authorities are warning that a spread to Asia could be serious since vaccine stockpiles are insufficient. Phylogenetic analysis identified 7 genotypes of yellow fever viruses, and they are assumed to be differently adapted to humans and to the vector A. aegypti. 5 genotypes occur only in Africa. West Africa genotype I is found in Nigeria and the surrounding areas. This appears to be especially virulent or infectious, as this type is often associated with major outbreaks. The 3 genotypes in East and Central Africa occur in areas where outbreaks are rare. 2 recent outbreaks in Kenya and Sudan involved the East African genotype, which had remained unknown until these outbreaks occurred. South America. In South America, 2 genotypes have been identified. Based on phylogenetic analysis, these 2 genotypes appear to have originated in West Africa and were first introduced into Brazil. The date of introduction into South America appears to be 1822. The historical record shows an outbreak of yellow fever occurred in Recife, Brazil, between 1685 and 1690. The disease seems to have disappeared, with the next outbreak occurring in 1849. It was likely introduced with the importation of slaves through the slave trade from Africa. Genotype I has been divided into 5 subclades A through E. Asia, though the main vector also occurs in tropical and subtropical regions of Asia, the Pacific and Australia. Yellow fever does not occur in these parts of the globe. Proposed explanations include the idea that the strains of the mosquito in the East are less able to transmit the yellow fever virus, that immunity is present in the populations because of other diseases caused by related viruses, and that the disease was never introduced because the shipping trade was insufficient, but none are considered satisfactory. Another proposal is the absence of a slave trade to Asia on the scale of that to the Americas. The transatlantic slave trade was probably the means of introduction into the Western Hemisphere from Africa.